Hey everyone, Dr. Shahid here, and in this video I'll go over the high-yield information you need to know about fixed partial dentures, or as most people call them, bridges. Alright, let's begin with a brief overview of crowns and FPDs. Simply put, a crown's a single tooth prosthesis that covers over the clinical crown of a tooth, while an FPD is a multi-unit prosthesis that replaces a missing tooth. There are several components to an FPD that we should be aware of. The abutment teeth are obvious, but we also have the retainers, followed by the Pontic, and the connectors as well. The retainer is the portion of the FPD that sits on top of an abutment tooth, the tooth we've prepped. The Pontic is the portion of the FPD that fills the edentulous space, and finally the connector is the portion of the FPD that connects the retainer to the Pontic. Let's go into each of these components in a bit more detail since you're likely to encounter questions regarding these components on your exam. The retainer is a crucial component of the FPD since it's actually responsible for supporting the entire prosthesis. Therefore, it should always be placed on teeth that have sound periodontal health, and it should not be placed on teeth that have been endodontically treated, as there's less internal dentin present to provide support. One factor we have to consider when evaluating abutment teeth is the root form. Between conical and irregular root forms is preferred. Furthermore, long roots are preferred over short roots for maximal support of the abutment. Additionally, an abutment tooth should have minimal bone loss, and a crown-to-root ratio of at least 1:1 is required, but a 1:2 crown-to-root ratio is ideal. Remember, the abutment teeth will be taking the load placed on the Pontics from occlusal forces, so it's crucial that they have sufficient support. And speaking of roots, there's actually a law that segues really nicely into this topic. You guys know what that is? And if you guessed Ante's law, you'd be right. Ante's law states that the total periodontal surface area of the abutment teeth for a planned FPD must be equal to or greater than the total periodontal surface area of the teeth being replaced in that FPD. Let me put this in simpler terms. The root form of the abutment teeth must be at minimum the same size as the root form of the missing teeth. So in this case, the surface area of the abutment teeth shown in purple is pretty much equal to the surface area of the missing teeth, and therefore, Ante's law would tell us that this 4-unit FPD is a structurally valid treatment option. So you can probably imagine why having multi-rooted teeth as abutments is preferred over single-rooted teeth. The prognosis of an FPD is greatly increased when the surface area of the abutment teeth exceeds the surface area of the teeth being replaced. But what if Ante's law is not obeyed? In this example, the edentulous area spans 3 teeth, and so the root surface area of our abutment teeth has remained the same, shown in purple, while the root surface area of the teeth being replaced has increased. In this scenario, Ante's law is not obeyed, and so in order to make this a valid treatment plan, we would need to look for a double abutment on one end of the FPD, or in other words, splint together adjacent abutments. So let's say we had a third molar behind our distal abutment here that had good root form. Well, we could prep that tooth as well and have 3 abutments, although this type of splinting is typically done with the mesial abutment instead. Alright, so let's say we've decided to fabricate an FPD for a patient, but we're unsure how to design our Pontic. Well, there are 5 main Pontic designs to consider when planning an FPD. Each of these designs vary in their shape and proximity to the edentulous ridge. The 2 main factors that determine Pontic design are how hygienic we want our FPD to be and how aesthetic we want our FPD to be. First, we have the hygienic or sanitary Pontic, which doesn't contact the edentulous ridge at all. So, as you can imagine, this one isn't aesthetic, but it's very easy to clean because of the space. We generally consider sanitary Pontics in the posterior mandible where hygiene is crucial and aesthetics are not really a priority. So this is a high yield point for your exam, so definitely make sure to remember it. Next, we have the conical Pontic. This design is similar to the sanitary Pontic, but there's actually a point contact between the Pontic and the edentulous ridge, and this just allows for good hygiene with slightly improved aesthetics. Again, generally indicated for molars. Next, we have the saddle or ridge lap Pontic. So this design closely adapts the Pontic to the edentulous ridge, making it very difficult to clean. Because of the poor hygiene associated with this Pontic, it isn't really indicated in any situation. So if the lab ever sends you back an FPD and the Pontic sits on the ridge like this, please do your patients a favor and send it back. The next Pontic design is the modified ridge lap. And as the name suggests, it's similar to the ridge lap, but allows for improved hygiene. And that's because it only partially contacts the edentulous ridge, as opposed to complete contact in the ridge lap Pontic. So this partial contact is on the buccal or facial aspect of the Pontic, and while it's not as cleansable as the sanitary Pontic or the conical Pontic, it is more cleansable than the ridge lap. This Pontic design is pretty versatile, to be honest. You can use it everywhere, especially for maxillary premolars where you need a fine balance between aesthetics and hygiene. The last Pontic design is the ovate Pontic. This one differs from the others in that it usually requires surgery to create a concavity in the edentulous ridge where the Pontic is then embedded. So this is by far the most aesthetic Pontic design as it simulates the tooth naturally emerging from the gingiva. This Pontic is generally only done on anterior teeth with high aesthetic requirements. Alright guys, the last component of a bridge that we'll discuss is the connector, which, as the name implies, connects the retainers to the Pontics. There are two connector designs to pick from depending on the abutment teeth. The first is the rigid connector, which just means that the entire FPD is one solid piece or rigid. This connector design is used when we have a common path of insertion, and to be honest, this is how 99% of FPDs are fabricated. However, there are situations where we can't obtain a common path of insertion, either because it results in too much tooth removal or simply because of the positioning of the abutment teeth. And in these situations, a non-rigid connector has to be used. So a measly tilted molar is the classic situation that you need to be aware of. A non-rigid connector is great in these situations because notice how the non-rigid connector is not one piece like the rigid one. Rather, the design features a male and female component that lock into each other. So you're able to first insert the anterior part of the FPD and then the posterior, thereby removing the need to have a common path of insertion. The presence of a pier abutment is another indication for using these non-rigid connectors, but again, the most common one for you will be the measly tilted molar. Alright, I have one last thing I gotta mention about connectors, and it concerns their dimensions, particularly for zirconia FPDs. Cross-sectionally, both mesial and distal connectors need to be ideally 3mm by 3mm. This dimension provides a balance between maintaining sufficient strength to withstand masticatory forces, especially in posterior regions, and avoiding unnecessary bulk that could compromise the fit or aesthetics of the FPD. So burn those numbers into your mind when it comes to connector dimensions, just in case it shows up on exam day. So that covers everything I wanted to mention about connectors, so let's quickly test your knowledge with a couple practice problems. We have a 55-year-old male. Chief complaint: I am here for my appointment. Background on our patient history reveals that he is hypertensive and has early onset Parkinson's disease. As for medications, he is on a statin, imantidine, and levodopa. And current findings indicate an FPD preparation on teeth number 29 to 31 and poor muscle coordination. So the question reads, which Pontic design is most appropriate given the stem and clinical photograph? Pause the video if you need some time, but the answer is D, a hygienic Pontic. The key to getting this one right lies in the fact that the patient has poor muscle coordination, meaning they're probably not going to be the best with their at-home dental hygiene. And since this isn't an aesthetic area by any means, a hygienic Pontic design would be the best option. Ovate Pontics are highly aesthetic but tough to maintain, ridge lab should never be used, and modified ridge lab gives you a great balance between aesthetics and cleansability. Let's move on to a scenario-based question. A patient presents with a diluted FPD spanning from number 6 to 11. Decay is present on the finish line of number 11 as well as on the mesial aspect of number 12. What is the next appropriate step? As always, take as much time as you need, but the answer is C, remove decay and fabricate a new FPD. First of all, guys, we obviously can't just monitor the decay, we have to get rid of it. But FPDs are very precise restorations, and since the decay here is on the finish line of an abutment tooth as well as on an adjacent tooth, we'd be compromising the proximal contacts and the marginal adaptation of the FPD by just trying to retrofit it back on. So we'll definitely need to just treatment plan a new restoration once we restore the teeth back to optimal health. Okay, last question. Each of the following factors complicates the planning of a 3-unit fixed partial denture from number 18 to number 20, except one. Which one is the exception? Pause the video to get your answer, which is D, presence of number 21. Options A, B, and C all directly impact the success of our 3-unit FPD here, but we don't really care if the first premolar is present or not. It doesn't change the outcome of the 3-unit FPD. And with that, we are done. As always, here's a brief summary of the high yield points we went over. Thanks for watching, and see you next time.